So, cervical spine are the most common spinal injuries. They're responsible for about 65% of all of the spinal injuries. The areas that most commonly see are at C1 and 2, especially in the young ones, and down below C5 and 7. The other fractures in between, only about 20% of injuries. Okay. So when a patient comes into ED, what happens before they come and see us? There's two types of criteria that are generally used, the Nexus and the Canadian. Brian would know all about the Canadian. So the Nexus is the National Emergency X-ray Utilisation Study. Okay. The easy mnemonic for that is NSAID or NICSAID. So the N stands for neurological deficit. The S is spinal tenderness, especially in the midline. A is an altered mental state or decreased level of consciousness. I is intoxicated, and D is a distracting injury. That can be all sorts of things, like a long bone fracture, all those other ones. So yeah, if a patient involved in trauma comes in and has any of these criteria, then they'll come to see us. Okay, so the other one is the Canadian. Now this is more, I guess, for them doctors to decide about immobilisation more so than imaging. So there's high-risk fractures which are over 65 years, a dangerous mechanism, any paresthesia in the extremities, and there's some low-risk factors, which is just a simple rear-end crash, if they're up and about over in DEM, and if they're not tender in the midline. The other thing they look at is if the patient's able to rotate the neck around 45 each way without any pain. So if they're all low-risk factors and there's no high-risk factors and they're able to move their neck, then they generally won't immobilise them or come for imaging. And that's what the doctors here use, double-checked. That's why you often see all those things on there. So this is just a bit of a summary. This is the opposite to how I said it. This is the saying that none of these things. So if there's none of them, then there's none. And if there is one of them, then they come and see us. And this is just a quick summary of the Canadian. You can read that. Everyone's read that. Yeah. That's, yeah. Alright. So this is just a quick summary of what we do. Everyone should know, hopefully. There's the standard 3 views, the AP, the PEG and the lateral. Other ones can be the obliques or the swimmers. I'm only going to talk about the main 3 though. I've read that over in the United States, pretty much it's advocated that CT is just becoming the standard for trauma, and it's expected to be the standard in the next couple of years. So that's the AP. That's the dontoid. That's the lateral. Alright, so image evaluations, they go by the ABCs. So the A, any ideas? Fran? What's the A stand for? What's the A stand for? Ampersand. So it's adequacy and alignment. Fran? What's the A stand for? What's the A stand for? Ampersand. So it's adequacy and alignment. So, I mean, I'll talk a bit more about all of those things later, but it's just make sure everything's aligned. The B, Kenny. Bones, very good. Bones. So you're just looking for any fracture lines. Make sure that the anterior and posterior vertebral heights are approximately equal, and pay particular attention to pedicles, facets, and spinous processes. C, Courtney, because C's for Courtney.
I don't know.
Don't know?
No.
Cartilage. So it's just to look at the disc spaces. They should be pretty much symmetrical. And the S, ooh, Stephen, S for Stephen. I reckon, no, nothing. Soft tissue's very good. So the lateral view is the most useful for this. It can tell you about fractures that you can't always see. We'll talk about this later. Smiley face. So this is the A's. This is just the alignment, just drawing lines down the sides. Pretty good. Spinous processes are aligned. Then you're happy. Spin. Yeah. Dun, dun, dun. Alright, that's the odontoid. So again, you're looking your alignment of the facets is C1, 2, and then the atlantoaxial space should be about 2 millimeters each side of the dens. Hey, come on, I've never used it before. There you go. So the lateral is the most useful for trauma evaluation. That's why, many places do the lateral as part of their trauma series over in DEM. There's 3 lines that you can look for alignment, and then the pre-vertebral soft tissue measurements. So these are the 3 lines. You've got your anterior longitudinal, your posterior longitudinal, and the spinolaminar. And obviously they should be pretty, consistent with each other. There's some measurements, but I'll talk about that in a second. Okay, so the soft tissue measurements are usually at 2 levels. The retropharyngeal at C2 should be no more than about 7 to 8 millimeters, but that can change if a patient has an ET or an NG tube in, and also if there's a naughty child. And then the pretracheal space at C6, that should be about 22 mils in adults and no more than 14 in children. Any widening of these spaces can indicate underlying pathology. And why might that be, Jody?
It's swelling.
Yeah, very good. Like hematomas. Yeah, cool. So yeah, it's vital for them to be on the projection. You're looking at the bones, but this is important to keep it on as well. So they're the levels. The white arrows are at C5. They're at C5. I think that was a mistake from the website more than anything, because anyway. So there are other things that can affect these measurements. So this patient had obviously, looking at C2, it looks like there's quite a big widening. What probably happened was this patient swallowed during the exposure. You can ask them to open their mouth at the time of exposure, but I don't know. Would anyone follow that? It's pretty quick exposure. You'd have to be pretty unlucky. But obviously with a crying kid, it's pretty hard to control. That's just a close-up here. Yeah. So now we're going to talk about the mechanisms. Hyperflexion, hyperextension, axial loading, and then complex, which is just all the others. So hyperflexion, Mexican wave. So it's pretty self-explanatory really. It's the most common, it accounts for about 50 to 80% of all injuries. Whiplash is probably one of the more common ones. The flexion forces are maximal at C4 to 7, the anterior portion. Okay. So some of the common fractures accounted in here is the flexion teardrop and the clay shovelers. Can also cause sprain in the posterior ligaments, and it's easy to, not easy, but one of the things you can see on your x-ray is a widened posterior and a narrowed anterior disc space. That can suggest that there might be a hyperflexion sprain. So flexion teardrop fracture. Most devastating flexion injury usually occurs in the lower C-spine, and diving into a shallow pool is a quite common cause. In about 90% of the cases, there is immediate, complete and permanent quadriplegia. So that's pretty bad. You don't want that. Okay. What will we see on the x-ray? We'll see a vertebral body fracture with triangular fragment coming from the anterior inferior corner, and the central vertebral body won't be involved, but it will be displaced posteriorly. So obviously that's going to cause some problems with the spinal cord. And that's just, I guess, a picture of the mechanism. That's the flexion, that's the fracture. And then the red's bad. So clay shoveller's fracture. This is an avulsion fracture of the spinous process of C6, 7 or T1. So it's a result of abrupt flexion against the interspinous ligament. It is stable, and what you may see on your AP is a double spinous process sign. I couldn't find that though, so that's it there. And that's it in a diagram. Okay, so move on, hyperextension. What do you reckon that might be from, Fran?
Falling asleep.
Yeah, extensive extension. Yeah, that's alliteration at its best. Yeah. It's less common than hyperflexion. It accounts for about 19 to 38% of C-spine injuries. And the most common fracture here is the hangman's fracture. Okay, so the hangman's fracture is fairly common. It's about 5% of all the injuries you'll see. The characteristics you'll see is an oblique C2 fracture on the lateral view. You might see a mild anterolesthesis, and this is coming back to the spinolaminar line. You'll see that posteriorly displaced. So there's 3 classifications. Type 1, the most common, is just a hairline fracture. Type 2 is a fracture where you'll see a displaced C2 and a disrupted C2-3 disc. Type 3 is just a really bad one, which is very unstable. But yeah, type 1's the more common. So here's a quick diagram. Type 1, hairline fracture, and there's no displacement. The disc is normal. Type 2, the fracture, you can see C2 is obviously displaced, and the disc is abnormal. And type 3, very displaced and very unstable. Okay. So, who wants to win a trip to Paris? Oh. So, anyone want to have a go at telling me which type this one is? I'm not going to scold you if you get it wrong. But I forgot my whip.
Is that your C2, is that your hangman?
Yes, it's a hangman's. Which type though?
Oh, okay.
1, 3.
1. Who said that? Okay, so Paris is what they're calling rehab now. So yes, it's just a hairline fracture you can see here on the lateral. The disc is normal and there's no displacement. So let's get rid of this. Yeah. Alright. Axial loading. Yeah. So, fairly uncommon, it's only about 4% of injuries. It will only occur in a neutral position, when the neck's in a neutral position. When it occurs at C1, it's a Jefferson fracture. It can occur lower down, however, it's less common. So, does anyone know why C1 would be quite commonly broken in this sort of injury? Yeah. Yeah, because it doesn't have a vertebral body, it's just a ring. Yeah, that was cool, that was a big spin. Yeah, so it's a burst fracture basically. As I said, doesn't have a vertebral body, it's just a ring of bone, so it's especially vulnerable. In the type of fracture, axial compression drives the occipital condyles toward the superior articular surfaces on the atlas. It's generally a bilateral fracture. It can be anterior, posterior, or both. And radiographically, it's characterised by bilateral displacement of the lateral masses of C1, and that's best visualised on the peg projection. And on the lateral, all you may see is the soft tissue swelling. So, what should the space be at C2, Liz?
Greater than 2 mil.
Oh, close. On the lateral. The
The anterior one.
yeah. Oh. about 7 or
More than
8.
normal.
So yeah, so you might, yeah, exactly, yeah, you'll see a bit more than normal, yeah. And CT is the best modality for the bilateral fractures to work out, to define them.
Oh, yeah.
That one's one of my favourites. So this is a schematic diagram, I suppose. So that's basically, as you can see, a burst fracture through the rings. And on the peg projection, that's what you'll see. So when you're lining up your facets, there's displacement laterally at C1. And that's highly suggestive that there's been a burst, and that's why they're sticking out. Alright, odontoid fractures. So, most common of C2 fractures, and they account for a fair amount of all the cervical spine injuries. Mechanisms can include flexion and or extension. Radiographically, prevertebral swelling may be the only finding. So, classified into 3 types, much like Hangman's fractures. Type 1 is just an avulsion at the tip of the dens. It's fairly rare, and it's quite stable. So type 2 is a fracture through the base of the dens. It's the most common, and it's always unstable and poor healing. Type 3 is fracture through the body of the axis and sometimes the facets. Can be unstable, but it does have a better prognosis than type 2, and that's due to it running through the metaphyseal bone of C2. I have to think about that word. So yeah, didn't you have one of these in CT yesterday, Liz? Or was it the other day, when you were in CT the other day? Didn't you have a odontoid fracture?
No, not me.
Not you, but the patient did.
No,
Oh, someone did.
she wasn't.
I thought someone had one, a type 2 one. Anyway, that's the differences. You can see there's the avulsion fracture through the base
Yeah.
and through the bone.
The lady.
Yeah. Didn't mean you.
No, I couldn't remember doing trauma, but she wasn't. She walked in.
So type 1, as I said, it's pretty rare. It's avulsion from the alar ligaments, excessive force on the alar ligaments. It's a stable fracture as the fracture line is above the transverse ligament, and counts for about 8% of all odontoid fractures. So type 2. This is the most common, counts for about 60% of them, and it's a transverse fracture through the base of the dems, always unstable and poor healing. So, you can see it there. It's just, and type 3. This is through the body of the axis, can sometimes involve the facets. It's about 33% of the fractures. Can be unstable, but yeah, this is all just what was spoke about before, so that's what it looks like. See it through there. And there's a 3D volume rendering picture. Alright, so what kind of patients do we like? Do we like that one? For a C-spine? Don't like that one? Nah. How about this one? Nah. What about this one? Oh yeah.